When we have a patient that we think needs a medication for MS, what I do is I talk to them about the goal of treatment. All right. It's interesting. Before we had many treatments out, we did not have a clearly defined goal, because if a patient had more disease activity, we did not have many more medications to turn to. So now, though we have so many medications in our toolbox, that we actually have defined a goal. It's called NEDA, no evidence of disease activity. So what I tell a patient is, this is you today. We're going to put you on a medication, and our goal is that from this point on, we do not see any signs of the MS continuing to be active. So that means no new lesions on your MRI, no new relapses, so you don't come back to me and tell me you're having new symptoms, and that your examination looks steady from visit to visit. I always tell patients I'm not tied actually to the treatment. I'm tied to the outcome. I want your MS to be steady. I don't want any new lesions or any new relapses. And I feel fortunate because in today's world, we actually can make that happen for most people. Shared decision-making is this idea that doctor and patient would decide together what the best treatment for that patient is. It shouldn't be all the doctor's decision, of course, what treatment that patient is going to be on, but we also don't want to leave it up to the patient, because the doctor does have the experience and expertise that could help with that decision. And so together, hopefully what would happen is doctor and patient sit down and decide what the best treatment option for that patient is. The goal of shared decision-making is for the patient to completely understand what the benefits of the treatment would be, what the risks would be, what the side effects would be, and to make the best treatment possible going forward. It's really important to me that when a patient starts on an MS treatment, that they feel comfortable with the treatment that they're going to be on. I feel really passionate about that, because if a person's taking a treatment and they worry about it all the time, or if they're having bad side effects from that treatment, they're not going to want to be on their treatment, and they're not going to feel like that treatment's helping them. And so I think it's important to sit down with a patient. It really should be a second visit with a patient after the diagnosis is made, where doctor and patient sit together and talk about what the patient wants. I really respect a patient who tells me that they want to think about all their options. If they want to think about going on to a treatment, or if they want to stay off a treatment. But, I believe my job is to really give them a full view of the risks of not being on a treatment before they would make a decision not to be on a treatment. If left untreated, what we know from our studies is that most patients that had relapsing remitting MS did at some point develop secondary progressive MS. That was the majority of the patients before treatment. We think that's if the immune system, if it causes so many attacks, that at some point the brain and the spinal cord just become vulnerable to the progressive course.